Hi friends, welcome to today's class. Let me know quickly if I am audible and visible. Just let me know and then we'll start with today's class. Hello, Dr. Preetham. Hello, Dr. Deepak. Just let me know quickly if I am audible and visible and then I will start with today's class. Hello, Dr. Teerth. Hello, Dr. Preetham. Hello. Good evening, Dr. Pratyusha. So, welcome to today's class on cord prolapse. So, today's class is just going to be a continuation of whatever we have done in the last 2, 3 classes, which was when we talked about breech presentation and when we talked about oblique lie. Sorry, when we talked about transverse lie. Do you guys remember? So, we talked about breech and we talked about transverse. So, in transverse, I told you transverse has no mechanism of labor. If you guys do you remember, it has no mechanism of labor. We are going to straight away do a cesarean section if we are not able to make it cephalic by ECV, right? But if it is breech, then we can go for a assisted breech vaginal delivery, or we can go for a cesarean section if we do not convert it to cephalic. Do you guys remember? Hi, Dr. Advitej. Do you guys remember this? So what we are going to talk about today is something called cord prolapse. So remember when I was telling you about breech and when I was telling you about transverse lie, I kept telling you one thing, that when the cervix is dilating, what is happening is in cephalic, the bone, the skull bone is tightly opposed to the cervix. So there is no space as the cervix is dilating कि कुछ बाहर से निकल जाए, कुछ बाहर निकल जाए, that something pops out, something slips out, right? But if you have a fetal part that is not very well applied to the cervix, या तो fetal part इतना ऊपर पड़ा हुआ है, cervix is not closed, then the cord can fall out, right? Or if the fetal part is small, irregular, like if they are feet, and as the cervix is dilating, there is space around the feet and the cord can fall out, right? So this is cord prolapse. So do you guys remember we talked about this? Do you guys remember? So remember cord prolapse is a dangerous complication. It is a dangerous complication which can lead to a lot of problems. What are the problems that it can lead to? So if the cord is falling out, what is going to happen? This is the cervix. This blue thing is the cervix, right? What is happening is that this is, for example, the fetal part. This is the fetal part, right? And this cord is falling out. This cord is falling out, for example. There is a loop of cord that has fallen out. What do you see over here? Number one thing that is happening over here is that the cord gets compressed. Cord gets compressed between the fetal part and the cervix, right? So it is getting sandwiched between these two things. That is number one. Number two thing that is happening is that inside the mother's body, the temperature is slightly higher and outside it is colder, right? So the part that is exposed, and whenever there is cold, what happens to the vessels? There is vasoconstriction. So this is going to lead to vasoconstriction. So all in all, what you can see is this umbilical cord, it contains, what does it contain? It contains fetal blood vessels, right? And what is happening over here is that because the cord is getting compressed, good evening, Dr. Bhumi, because the cord is getting compressed, the vessels inside the cord are getting compressed. And now there is no blood supply that is going to the baby, right? The baby is going to go into hypoxia. This is going to lead to hypotension and bradycardia in the patient, in the fetus. And eventually, what is going to happen is the fetus can land up in an intrauterine death sort of a situation. The fetus may die, or there might be hypoxic brain injury to the fetus. So, this baby that is born may have hypoxic brain injury and may not behave, may not have normal milestones, might be a little delayed, might have delayed milestones, or may even suffer from cerebral palsy. Right. Good evening, Dr. Sonu, Dr. Anuvansh. Right. So I hope this is clear. So this is why cord prolapse. This is why cord prolapse is very, very dangerous. Right. And I told you that cord prolapse is happening when one of the things that I told you is when the presenting part is not very well applied to the cervix, right? So one thing could be, yeah, that your presenting part is high up. The second thing could be that the presenting part is not high up, it is applied to the cervix, it is close to the cervix, but the presenting part is not occluding the cervix very well, right? So this could be in the case of malpresentations like transverse, like breach. And in breach, remember, it is maximum in maximum in footling breach, right? In breach, the incidence is near about 1%. Incidence of cord prolapse is near about 1%, right? So the cervix may also not be occluded very well in case of very small baby. If the baby is preterm, in case of second twin, because it may be transverse, in case of polyhydramnios, in case of polyhydramnios. Got it? So these are the reasons why the cord could suddenly slip out of the cervix into the vagina or out of the body, and this could cause huge problems in the fetus. Right. So this is about your cord prolapse. So I have told you why we are scared of cord prolapse, why it is so dangerous, right? And who are the patients जिनमें मुझे शक होना चाहिए, I should have a reasonable doubt, I should be very, very careful while dealing with these patients in labor because there is a high chance of cord prolapse, right? So let us talk about one simple thing first: cord presentation versus cord prolapse. So presentation means what? The part of the fetus that is occupying the lower uterine segment. So cord presentation will simply mean what? That in the lower part of the uterus, the cord is present, right? And this will typically, so cord is present between your presenting part and your cervix, right? And typically, when you do a per vaginal examination, you will feel a bag of membranes, and inside that bag of membranes, you will feel the umbilical cord-like structure that will give a typical bag of worms feel. Bag of worms feel. Right. And if by chance these membranes were to rupture, what will happen? The lowermost part of the fetus that is there, that is the umbilical cord. So the umbilical cord will fall out, right? And that is going to be cord prolapse. So cord presentation, if you have membrane rupture in cord presentation, there is going to be cord prolapse, which I have already told you is an obstetric emergency, which is why if you have cord presentation, if you have a patient who has a typical bag of worms appearance, feeling on per vaginal examination, you are going to do a cesarean section. You are going to do a cesarean section. I hope this is clear. Now, cord prolapse, on the other hand, is cord falls below the cervix. It falls below the cervix into the vagina or out of the body, or out of the body, right? So this is an obstetric emergency. This is an obstetric emergency, right? Why? Because the fetus can die. Because the fetus can die. So this is about cord prolapse and cord presentation. Now, how will you diagnose it? By chance, these are the women who had high risk factors, right? And now you have to diagnose. See, because it is an obstetric emergency, it is very, very necessary that you diagnose cord prolapse very, very soon, right? So never say ultrasound, but on ultrasound, what you can see is before the cord prolapse, you can see cord presentation, but ultrasound is rarely ever used or never used, right? But what we actually do find is that typical history is typically there is a membrane rupture, and with the membrane rupture, the cord falls out. The umbilical cord gets compressed, and within it, your fetal blood vessels also get compressed, right? And what will happen? Variable compressions, variable decelerations. Remember, variable decelerations में क्या हो रहा है कि there is cord compression during contraction, and then as the contraction goes away, it is getting relieved. So the cord is जो आपकी constriction हो रहा था of cord vessels, that is being relieved. Over here, what is happening is that this cord is permanently stuck between the head and the cervix, and it has also fallen down, and because of the cold, there is a permanent vasoconstriction. So typically what you're going to find is, look at this mother is in labor, this is a cardiotopograph, fetal heart एकदम ठीक चल रहा है, fetal heart is going absolutely fine, right? This is your fetal heart, this is going absolutely fine. And then suddenly what you found was that after the membranes ruptured, the fetal heart suddenly dropped. It suddenly dropped and it never came back up, and this baby then died. Right? So, Dr. Anuvansh, this is what will happen. You might not see variable compressions. What you might see is a very huge deceleration that fails to come back up. You may see variable decelerations also, but this is typically what you will see, right? Is that clear? The other thing that you might feel is when you do the pervaginal examination, you might find a cord-like structure with or without pulsations. And when you do a per speculum examination, what you see is the cord lying outside of the cervix, When I say when you do a per vaginal examination, you might feel a cord-like structure with or without pulsations. What does this mean? With pulsations means baby is still alive. And without pulsation means what? The baby has already died. Right? So this is how you will diagnose it. Now, once you have cord prolapse, right? How will you manage it? So remember the basic management. This baby is in danger right now. This baby may die because of a permanent compression of the fetal blood vessels. So I need to take this baby out fast, no matter what the route, right? So what I need to look at is fetal heart rate status. So fetal heart rate status can either be non-reassuring, which is more likely in the situation. तो अगर fetus का heart rate non-reassuring है, which means there is fetal distress, in that case, what will we do? We will do a cesarean section. And we will likely do it under general anesthesia if the fetal heart is non-reassuring. Now, the other situation could be कि बस variable decelerations आ रहे हैं, इतना dip नहीं हो रहा, या फिर the fetal heart is still reassuring. Now, if it is reassuring, still, right? This will not remain reassuring for long because the fetal blood vessels are going to start constricting. So in that case also we will prefer LSES unless and until of course vaginal delivery bus hone hi wali hai, right? And this can be done under regional anesthesia. This can be done under regional anesthesia if the baby is not in distress. So आप spinal लगा के दे सकते हो. Now, what if on the FHR status I find that there is an intrauterine death? तो ये जो हम भाग भाग के LSES कर रहे थे, all this hurry that we were trying to cause and we were trying to do an LSES, why were we doing that? Was it for the mother? No, we were doing it for the baby so that we can get the baby out alive. Now the baby has already died. Why would I cut open a mother if the baby has already died? It's giving her unnecessary surgery. So if there is intrauterine death, you do a vaginal delivery unless it is contraindicated. What do I mean unless it is contraindicated? Remember, malpresentations is a very big cause of cord prolapse. So it could be that there has been a cord prolapse because the baby was in transverse. अब transverse lie में अगर baby है, there is no mechanism of labor, there is no way that it can come out vaginally. If I leave it to have contractions कि आप vaginally deliver करो, we discussed about this in the last class, what is going to happen? There will be obstructed labor, there will be a Bandel's ring formation, and finally the uterus will rupture. Finally, the uterus will rupture. I will sum it up, Dr. Monsieur. I'll sum it up and then it will become easy. Right. So vaginal delivery, unless it is contraindicated, example in transverse lie. Example in transverse lie. Right. So just sit with me through this. I will make it very easy at the end. Right. We will sum it up and it will become very, very easy at the end. Right. Uh, yes. So I will just give you a true story. I will just give you a true story as an example. When I had just joined post-graduation, I was a young postgraduate, right? So उस time पे आपको कुछ पता नहीं होता, you don't really know anything, you don't even know how to do your pervaginal examinations, right? So what happened was that we were in the labor room and I was very, very excited. So if you remember the WHO guidelines, if any of you have read it, तो बोलते हैं कि आप early ARM मत करो. Don't do artificial rupture of membranes, right? Why? Case in point, I went there, I saw कि अच्छा cervix dilate हो रहा है, खुला हुआ है, labor will become faster. Let me rupture the membranes. I ruptured the membranes, right? The head was very high up. The cervix was here, cervix यहाँ पे है, head यहाँ पे है, right? I ruptured the membranes. When I ruptured the membranes, the fluid rushed out, and with that rushing out, the cord also came out, right? Now, I did not know at that time what a cord prolapse feels like. So when I'm doing my PV, I called out to my senior and I said that, ma'am, there is something weird I feel. I don't know what this is, right? And when she came, she was like, what is it? What is it? Right. And I was like, I don't know. It's pulsating a lot. And her eyes just widened. Right. And she was like, don't take out your hand. Don't take out your hand. Right. तो उन्होंने मुझे बोला अपना हाथ बाहर मत निकालो. पीवी कर रहे हो, पीवी करे रहो, पीवी करते रहो, and don't take out your hand. But being the stupid, new first year PG that I was, I took my hand out. Right. And then what happened is basically how you manage cord prolapse. Then what happened is basically how you manage cord prolapse. So what we do in cord prolapse is कि main problem क्या आ रही है कि your fetal blood vessels are getting compressed, right? वो head cervix के बीच में उसको दबा रहा है, right? So why my senior told me don't take out your hands was कि she was saying कि अगर वो cervix पे head ऐसे आ रहा है and it is compressing the umbilical cord, then with your PV, you push the head up. You push the head up so that the umbilical cord is no longer compressed. So with the PV, what you are doing is you're pushing the presenting part up so that the umbilical cord is not getting compressed by the presenting part. In the meanwhile, what she said was कि फटाफट OT ready करो, फटाफट OT ready करो. Now, because I had already taken my hand out, she put her hand in and she elevated the presenting part. The next thing she told me was फटाफट इसको कैथेटराइज कर, ठीक है, कैथेटराइज कर, नॉट टू ड्रेन द यूरिन. शी मेड मी कैथेटराइज दिस पर्सन, एंड आफ्टर कैथेटराइजिंग द पर्सन व्हाट शी डिड वाज शी मेड मी कनेक्ट इट to a bag of normal saline, right? and we filled up the bladder retrogradely. जब हमने ब्लैडर को retrograde fill किया, the head was over here, the bladder was over here, the bladder lifted the head up and the head is now over here. So the cord is not getting compressed. So the cord is not getting compressed, right? So the first thing that she did was she pushed up the presenting part. The second thing that she did was, while she was screaming at everybody and managing ki anesthetist ko bulao, OT ready karo, what she did was retrograde. She asked me to do retrograde filling of bladder. Retrograde filling of bladder. Iska naam hai, this is called Vagos maneuver. This is called Vagos maneuver. This is called Vagos maneuver. Right? The other thing that she could have done was this position, right? You can assume this position also, या फिर आप इसको इस position में भी कर सकते हो, Trendelenburg position में. तो Trendelenburg position में करोगे, पहले यहाँ पे था, तो this will go up slightly, right? इसमें भी your presenting part is going up slightly and relieving the pressure on your umbilical cord. Or what you can do is you can place a wedge. You can place a wedge. So what we did that day was this and this, right? And quickly we put the patient on the trolley and we rushed her to the OT table. Now, when we rushed her to the OT table, the anesthetist asked GA or spinal, right? And my senior resident, who had her hand still inside, she felt the pulsations of the umbilical cord, which is the same as the fetal heartbeat. And she said, no, general anesthesia, fetal heart is 80 beats per minute. The baby is still alive, but the fetal heart is only 80 beats per minute. So remember, NST mein we had done what? The baseline should be between 110 to 160 beats per minute, and this baby had a heartbeat of only 80 beats per minute. And we were like, no, quick, we need quick anesthesia, do general anesthesia. So the anesthetist gave general anesthesia. Another SR came from the ward because this SR's hand was already inside. And very quickly, she opened up the abdomen and she delivered the baby. And the baby survived without any neurological sequelae as such. The baby was fine. It had good Apgars when it came out, right? And once the baby came out, that is when the first SR removed her hand from the pervaginal examination, right? So what I mean to tell you over here is कि we had a chance at saving this baby. It was not yet dead, but it was in distress. So we took the call. What? The first call that we took was कि इसका फटाफट cesarean कराओ, fetal heart खराब चल रही है. The second call that we took was that it is already at 80 beats per minute. We do not have time for spinal anesthesia. Please give general anesthesia. We need it to be fast. That was the second call that we took. Now, the situation could even be कि उसका fetal heart ठीक चल रहा है, 120, 130 चल रहा है. In that case, we could have opted for spinal anesthesia also. But usually in cord prolapse ऐसे नहीं होता है, right? ऐसे भी हो सकता था कि जो baby है वो एकदम आपका जो cervix है that is almost fully dilated, fetal heart ठीक चल रहा है, baby is allowed to deliver. In that case, you can give for a trial of vaginal delivery. But usually, more often than not, 99%, your cord prolapse will require a cesarean. अब ये भी तो हो सकता था when my SR had put her hand inside, right? When she felt the cord pulsations, she felt nothing. What would that mean? That would mean that the baby has died. Right. Now, if the baby has died, why should I cut open the mother's abdomen? It is a major surgery, cesarean. So in that case, if the baby has already died, we would have augmented her labor and we would have allowed her to deliver normally, vaginally, right? Except if there was any contraindication to vaginal delivery. जैसे अगर baby transverse line में है, vaginally it cannot come out. Right. So this is what is the management of cord prolapse. The definitive management is going to be taking out the baby as soon as possible if it is alive by cesarean section. Depending on heart rate कैसा चल रहा है, you can choose your anesthesia. In the meanwhile, जब तक patient OT में पहुंच रही है, till the time she is reaching the OT, you can do certain temporizing measures like putting a wedge underneath, or the Trendelenburg position, or pushing the fetal part high up, or doing retrograde filling of the bladder. So these are certain things that you can do till the time the patient reaches the OT table so as to relieve the pressure on the umbilical cord. Sometimes it might so happen we were lucky because we had an OT just next door to the labor room. It might so happen that this woman is undergoing a trial of labor, or she is, trying to deliver at a PHC or at a small hospital that does not have an OT, right? In that case, she will be transported by an ambulance, right? So ambulance wale kya karenge fir? These are the measures that they can use. They can put a wedge underneath her hips, keep her in Trendelenburg, right? ये जो आपकी position है, इसमें आप बहुत लंबे टाइम तक you cannot expect the woman to stay in this position. So the other things, this is actually the most effective, but it is not very practical. So we end up doing the other things. So this is your management of cord prolapse. And finally, now that you know that it is such a dangerous situation for the baby, how can we prevent it? Number one, if you have malpresentations like transverse lie or oblique lie, do not let them go into labor or have their membranes rupture outside the hospital. You admit them at 37 weeks, whether they are in labor or not. Whether they are in labor or not. Right? And prevention में the other thing that WHO says, do not do early or unnecessary ARM. ARM. Is this clear, guys? Is this clear? Does this make sense? So this was a very small, very short topic. So I hope this makes sense to all of you. Yes, exactly, Dr. Missio. So any midwife or doctor can do it to lift the head. So PV में हम क्या कर रहे हैं? We are just lifting the head up a little so that the cord compression gets relieved. Absolutely. I hope this is clear. So cord prolapse is a very small topic, very short topic, very easy topic. बस आपको एक चीज समझनी है. Number one thing that you understand is cord prolapse में the cord is getting compressed, which means the fetal blood vessels are getting compressed permanently. So that can lead to IUD and brain injury in the baby. So this baby needs to be taken out fast. That is the takeaway. You have to take out the baby fast. How do you take out the baby fast? By a cesarean section. Now, what anesthesia you use will depend on fetal heart kitna kharab chal raha hai. GA will give you a faster anesthesia so you can take out the baby faster, right? And transportation to the OT mein, there are certain measures that you can use, like retrograde filling of the bladder, which is Vagos maneuver, or you can lift the presenting part up, or you can use Trendelenburg position, or use a wedge. So that is it about cord prolapse actually. So you need to know the risk factors ki malpresentation koi hoga, so that is at a higher risk. So whenever you have a patient who has breech or who has transverse lie and they are in the ward, they are not even in labor. Anytime they have a rupture of membranes, you have to be very, very careful. You have to be very, very alert कि कहीं cord prolapse तो नहीं हो गया. Right. So important question for exam is basically going to come either from this. Vagos maneuver is a question that has been asked in the past. Right. And the other question that they can ask you is the definitive management. So management will include your temporizing measures also, and it will include this also. Do you think if a preterm baby comes like this, will you have time for steroids? No, you will not have time for steroids. This is what we call a category 1 cesarean section. This is what we call a category 1 cesarean section. Category 1 cesarean section means within 30 minutes आपको करना ही है. Within 30 minutes you have to do it. There is immediate threat. There is immediate threat to life of mother or fetus, and that is why you have to do it in 30 minutes or less. Right. So the question that they typically ask you is the management and risk factors of cord prolapse, and that is all that you should know. Right. So that is it for today's class. I hope you understood. And if there are no other doubts, I will see you in the next class. Right. Any questions, guys? Okay. Thank you. Thank you for sitting through this class. So I will see you again next Thursday for the next class. Thank you. So are you guys understanding the labor room series? कुछ समझ आ रहा है? थोड़ा थोड़ा समझ आ रहा है? Please go back to your lectures and keep revising. It is very important to keep revising, right? Because labor is a difficult topic. Even postgraduates find it very difficult, right? But unfortunately, it is a topic जो आपसे MBBS में पूछा जाएगा, definitely in your viva, in your MCQs, in your written exam questions, right? So please make sure that you revise. Okay.